Bismillah ar-Rahman ar-Rahim. Today we will continue our KB program. Today is episode 4 under title of Catheter Induced Dissection of Normal Right Coronary Artery Reappraisal of Underlying Mechanisms. Actually, this case report was published in Egyptian Heart Journal in 2016. This case is actually based upon how to explain an iatrogenic dissection that could happen in daily practice inside the cath lab. But really, I put hypothesis in this particular case. To go fast, our case presentation is a female lady, 52 years old, obese, hypertensive, dyslipidemic, and not diabetic. She was complaining from repetitive episodes of typical retrosternal chest pain since 2 years. To some extent, the pain was on exertion and in some location relieved with rest and nitroglycerin. ECG shows non-specific T-wave inversion in inferior leads, and resting echo was quite normal. The stress ECG showed subtle ST segment depression in inferior lateral leads in the third stage when patient developed chest pain. The routine lab investigation was quite normal, and decision-making was in favor of doing coronary angiography as other diagnostic modalities. For example, CT coronary angiography was not available at that time. The coronary angiography procedure was a regular femoral approach. The left system revealed normal coronary artery, and the RCA was cannulated by ejector right 3.5, 6 French catheter, and there was no any aggressive manipulation of the catheter, and an easy cannulation was done. But unfortunately, catheter-induced dissection of the proximal RCA was accidentally committed, and the trials of non-selective cannulation were done and revealed no osteal lesions, and the patient suddenly complained of severe chest pain. ECG ST segment elevation in inferior leads was occurred. To go fast, we decide to fix this dissection with PCI. The right coronary artery using Jatco right 4, 6 French guiding catheter. P medullary flip wire was successfully crossed to the distal end of the RCA. Maverick balloon 2 by 20 mm mercury was used to produce dot ring maneuver as to replace the dissected flap again and to measure the length of the dissected flap. It was quite more than 30 mm long, with proximal inlet and the distal sighted exit just before the cross of the RCA. The inlet segment was fixed with 3.5 by 28 mm per meter stent deployed at 14 ATM, while the exit was fixed by 2.75 by 24 mm per meter deployed at 12 ATM, with nicely restoration of TM3 flow and the myocardial flush grade 3. Patient chest pain was resolved and the ECG changes improved, and there was no post-procedural cardiac enzyme elevation, and the patient discharged the following day. This is the angiogram, and this was a regular PCI. But the discussion here based mainly upon that I didn't accept what happened. So I start to search if there is any anatomical or histological background of the catheter-induced dissection. So I start to make a midline search, and there was several studies tried to show whether there is any anatomical and histological background of the catheter-induced dissection. In a study done by Jose et al., where they studied the structural features of the sinuses of valsalva and the proximal portion of the coronary arteries and their role in the pathogenesis of aortic coronary dissection, and they found that first of all, that the angle that the left coronary artery forms with the ascending aorta is acute, ranging about 20 to 55, and that of the right coronary artery 10. And the proximal course of the left coronary artery can provide a better approach for catheterization than the right coronary artery due to their coaxial alignment in relation to the ascending aorta. The second issue is that the diameter of the ostium of the left coronary artery was larger than that of the right in about 76% of their cases. And the third one is histologically, the left coronary artery has a greater number of smooth muscle cell set in large amount of type 1 collagen, and it is well known that type 1 collagen, in contrast type 3, has greater tensile strength, which could mean that the right coronary artery ostium is less resistant to traction and as a result could more easily give rise to a retrograde aortic dissection and a coronary intervention. But this is not really and I start to study what is about the deformation. On my midline search, a few studies had mentioned the aortic root deformation, but none of those mentioned the role of aortic root deformation dynamics in the pathogenesis of aortic coronary dissections. Several studies applied cinematography and the contrast injections have visualized aortic root motion, wherein the root is displaced downward during systole and returns to its previous position in diastole. Recent cine-MRI studies in health subjects revealed an axial downward motion of 8.9 mm and a clockwise axial twist of 6 degrees during systole. The force during the aortic annulus motion is the ventricular traction accompanying every heartbeat. This force is transmitted to the aortic root, the ascending aorta, the transverse aortic arch, and the supra-aortic vessels. So, thus, the aortic root motion has a direct influence on the deformation of the aorta and on the mechanical stress exerted in the aortic wall. In addition, early in vivo dynamic studies of the aortic root showed its significant expansion during the cardiac cycle, but without consideration of the possible asymmetry of each sinus. Recent dynamic studies with better instrumentations have shown in vivo that this anatomical asymmetry corresponds to a dynamic deformation of the aortic root. Dogma et al. And Emmanuel et al. Showed a heterogeneous torsion of the three sinuses of Valsalva, that is, one sinus twisting in the opposite direction to the other two. The underlying mechanisms and the physiological relevance of these findings is unknown, now related to the presence of the coronary ostia in only two sinuses and or dominance in the coronary circulation, because the non-coronary sinus never twisted in opposition to the other two. So from the previous study, I could hypothesize in my case here two kinds of changes or phenomena might happen at the site of aortic root. One is dependent on fluid dynamics, where the reflection wave of the arterial pulse, especially in hypertensive patients, where atherosclerosis could facilitate rapid reflection of pulse wave back to the aortic root, where it could make rapid vortex flow of blood at the sinuses of Valsalva, and that could make aggressive attraction of the catheter into the coronary artery. The second is dependent on the motion dynamics of the aortic root, where in hypertensive patient there are increased shear stresses on the aortic root walls, which make it relatively movable structure that may affect the position of the catheter while it is engaged inside the coronary artery, predisposing to dissection. So finally, to conclude, in hypertensive patient, there might be two phenomena at the aortic root. One is the flow dependent and the other is wall motion dependent. Both could affect the cannulation of the coronary ostia and may accidentally facilitate the occurrence of coronary dissection. And thank you.